With the propagation of point-of-care ultrasound, we're really starting to encounter these applications that are sort of outside the traditional imaging modalities that we think of ultrasound being used for. And one of the examples of this that has me most excited is point-of-care ultrasound in the emergency department to confirm endotracheal tube placement and to manage emergency patient airways. So often when I talk about this, people's responses are, well, don't we have enough tests already for endotracheal tube placement confirmation? We all know from early training in medical school that there are physical exam maneuvers like listening for bilateral breath sounds in the absence of noise over the stomach that can help us. And we know when we're training in the resuscitation environment that we're supposed to ask for the Untitled CO2 detector, either the colorimetric device or, if you're lucky enough to have one, then the quantitative scale on your monitor. But my argument back is that there are plenty of times in the acute care environment where these maneuvers and these existing techniques are going to fail us. And there's great literature about just how quickly and how accurately you can use an ultrasound transducer on the anterior neck to investigate for a properly or improperly placed endotracheal tube, namely an esophageal intubation. And I sometimes think that we're a bit burdened by the weight of history, where the physical exam and the Untitled CO2 detector have been around longest, and so they're what we all think of. But if you were starting just today and you had those techniques and ultrasound and you brought them all together and you showed them to trainees in emergency medicine and said, which one do you think is the best going forward? I think most people would pick ultrasound. So the drawbacks in the physical exam is that we know it's not highly accurate. Even the best studies done in the most controlled environment, in the operating room, in a nice quiet anesthesia environment without the chaos that surrounds a resuscitation, especially a pediatric resuscitation, show that the physical exam maneuver, in terms of its sensitivities and specificities, you don't get much higher than 80% of either for ruling out an esophageal intubation. And when you think about what a critical procedure this is to provide a patient with an airway, I feel like we need to really be getting up to numbers that are approaching somewhere around 100%. And the Untitled CO2 detector is great when it gives you a positive result. But we know for it to give you a positive result when you're in the airway, you need to be producing and exchanging CO2. And unfortunately, many of the patients that we receive intubated are just those patients who may not be doing that, namely arrest patients. So if your tissue is not producing CO2 because you don't have cardiac output, you may well have a tube in the trachea but not have any end-tidal CO2. So wouldn't it be nice if we had a method where you could do direct cross-sectional imaging of the neck to say, I've put a tube into one area of this neck, is it there or not? And this relies on some ultrasound physics that are pretty familiar to those of us who do ultrasound, which is the presence of air. So that you should only have one air-filled structure in your neck, and air, as we know, scatters the ultrasound beam and creates a dark shadow as it doesn't allow propagation of the vibration through a gas medium. So putting a probe in a transverse orientation on the anterior neck between the vocal cords or the suprasternal notch, with the suprasternal notch being sort of the flavor of the month in the literature, you should see only one air-filled structure. You may or may not see the esophagus. It is much easier in children than it is in adults to see it. And if you see two tracheas, in other words, you have two air-filled structures in your neck, there's only one thing that does that. Your esophagus is stented open by an endotracheal tube. So in this video clip, we start with two air-filled structures that gives you the characteristic appearance of the two-tract or two-trachea sign with an esophageal intubation. And you can then see as the endotracheal tube is removed and you now have only one air-filled structure, with a little bonus that in this child you can actually visualize the now empty esophagus also. Test characteristics for this exam are excellent. In many studies they are in the high 90s, approaching 100%, and it can be performed very rapidly. So it has me excited as a novel technique for improving our management of critical airways.